Hey everyone. Today we're diving into a really cool technology for the ICU that's a bit of a game changer. Electrical Impedance Tomography, or EIT for short. The big promise here is that it gives us a new set of eyes, letting us actually see what's happening inside the lungs so we can truly personalize mechanical ventilation for our sickest patients. Let's get into it. So picture this. We've all been there, right? You have a patient with severe ARDs, and you've dialed in what you believe are protective ventilation settings, but you're still kind of flying blind. Sure, you've got global numbers like compliance and oxygenation, but what's really happening regionally, deep inside that injured lung? Are you accidentally recruiting one part while you're overstretching another? This is the fundamental dilemma that EIT is designed to help us solve. So here's what we're going to cover in this explainer. First, we'll quickly break down why ventilating ARDS lungs is such a challenge. Then we'll see how EIT gives us a whole new perspective. After that, we'll jump into two really practical applications, titrating PEEP and monitoring therapies. And finally, we'll talk about the limitations, what's next for the technology, and wrap it all up with your key clinical takeaways. Okay, so let's set the stage. Why is ventilating a patient with ARDS so notoriously tricky? Well, the absolute crucial thing to remember is that ARDS creates this massively heterogeneous lung. You've got different things happening in different places. Because of gravity and the injury itself, the dependent parts, the back of the lungs, are often collapsed and full of fluid. Meanwhile, the non-dependent parts up front might be relatively healthy. So if you apply just one single PEEP setting, you run the risk of causing both ad-electrotrauma in those collapsed zones and volutrauma in the healthy zones. It's a classic catch-22. And this is exactly where EIT steps in. It offers us a way to visualize these regional differences right there at the bedside and in real time. So how does this thing actually work? It's pretty fascinating. A belt with a set of electrodes is just placed around the patient's chest. Then a tiny, totally imperceptible electrical current is passed between pairs of electrodes, and the other electrodes measure the voltages. Now here's the key. Air is a really poor conductor of electricity. It has high impedance. So, based on that principle, the device can create a dynamic, 2D map showing exactly where air is going with each and every breath. It's continuous, it's radiation-free, and it's basically like giving eyes to the ventilator. The fundamental measurement here is something called tidal impedance variation, or TIV. All that is the change in impedance from the end of expiration to the end of inspiration. What's so cool is that studies have shown a really strong linear relationship between this impedance change and the actual change in air volume in that region. So when you see a bright spot on that EIT map, you're seeing a large TIV, which just means a lot of air is moving into that specific spot. Now, from that one basic measurement, the software calculates some incredibly useful indices. You've got the Global Inhomogeneity Index, which tells you how evenly your ventilation is distributed. Then there's the center of ventilation, which shows you if air is going more to the front or the back of the lungs. And, maybe the most powerful of all, are the overdistension and collapse indices. These actually estimate how much of the lung is getting hurt at either the high or low end of the pressure spectrum. All right, let's see how all of this comes together in one of EIT's most promising applications, personalizing PEEP. We've all used the PEEP/FiO2 tables, but that's a population-based approach. The real goal with EIT is to find the PEEP that works best for this specific patient's unique lung physiology. We're on the hunt for that sweet spot, that perfect compromise PEEP that opens up collapsed areas without overstretching the healthy ones. And this slide shows us exactly how we find it. This is a decremental PEEP trial in action. If you look at the top row, those blue and white images are ventilation maps. At a PEEP of 20, you can see ventilation is pushed forward, which suggests the dependent lung is pretty well recruited. But watch what happens as the PEEP is lowered to 10, then 8, then 6. You can see the white, high ventilation areas shift dramatically toward the front as the posterior lung just starts to collapse. This graph is where we put numbers to that observation. The gray bars show you the percentage of the lung that's collapsing as PEEP goes down. The yellow bars show the percentage that's getting overdistended at those higher PEEP levels. The whole goal is to find where these two types of harm are at their lowest. And look at this. The point where the two curves cross, marked right here, suggests a PEEP of around 12. For this patient, that's the best compromise to minimize both injuries at the same time. Okay, so beyond just setting the ventilator, EIT is also an incredibly powerful tool for monitoring our other therapies, and we can do it in real time. Let's talk about prone positioning. We do it to improve oxygenation. We know it works, but what's happening physiologically? Well, this trend graph gives us an amazing visual. That top line shows the end expiratory lung impedance, or EELI, which is basically a stand-in for lung volume. Look at the red arrow. As soon as the patient is proned, you see this steady, sustained increase in EELI. That's direct visual proof of lung recruitment. But then, check out the yellow arrow. When the patient is put back supine, a lot of that gained lung volume is immediately lost. It's just such a powerful real-time confirmation of our therapy's effect. And the list of applications really doesn't stop there. EIT has been shown to be super sensitive for detecting a pneumothorax. You can use it to quantify how much lung volume is lost after suctioning, or even to predict weaning failure by seeing de-recruitment during a spontaneous breathing trial. It can even identify really complex things like pendeluft, which is basically when air just shifts from one part of the lung to another instead of coming in and out of the body properly. Now, of course, like any technology, EIT is not perfect. It's really important that we understand its limitations so we can use it wisely. So, on the plus side, it's real-time, it's continuous, it's radiation-free, non-invasive, and it gives us this unique insight into regional lung mechanics. But on the downside, the spatial resolution is low. This is not a CT scan. You're not going to use it for an anatomical diagnosis. It also only visualizes one slice of the thorax, and some of the indices can be a bit complex. And I think this is the most important point. While it's physiologically fascinating, we're still waiting on those large-scale trials to prove it improves patient-centered outcomes. The future, though, is incredibly exciting. I mean, just imagine combining this regional ventilation data with regional perfusion data, which you can also measure by EIT, to get a real-time VQ map at the bedside, or syncing it up with esophageal manometry to see regional transpulmonary pressures. We could get a view of lung mechanics that's more complete than anything we've ever had before. So after all that, what are the key messages you can take back to the bedside with you? Okay, first, EIT gives you real-time visual feedback on regional ventilation. It lets you actually see the effects of your vent settings. Second, it's a really powerful tool for PEEP titration, helping you find that individualized sweet spot between collapse and overdistension. Third, you can use it to monitor therapies like proning and get objective evidence of whether you're actually recruiting lung. And finally, always remember, while it's an incredibly promising physiologic tool, we're still waiting for more data to confirm its impact on hard patient outcomes. And that really leaves us with a fascinating question for the future. We monitor heart rate, blood pressure, SpO2 continuously. They're vital signs. As EIT gets better and more accessible, could monitoring regional lung mechanics become just as fundamental? Could it be the next vital sign for our ventilated patients? And that's it for this explainer. If you found this deep dive into EIT helpful, do us a favor and hit that like button and subscribe for more explainers on critical care topics. Go ahead and share it with your colleagues, and we will see you in the next one.